welcome to Lina and Rada's show. Very happy to have you today for another show, old TG versus new TG.
Yes, and as you can see, we are wearing the same thing that we were wearing the past videos because as you guys know, we have recorded some episodes just in case we move to a stage 4 and we are no longer able to meet each other face to face to do the live session. So it's not just because we don't have any more clothes like this. It's because pretty much we did a bunch of videos and episodes during the period of one day. So okay, Rada.
So
Tell me.
We're going to talk about antibiotic prophylaxis. So there are quite few changes in this one. So first of all, we want you to just get the thing that they no longer say antibiotic prophylaxis, but rather surgical antibiotic prophylaxis or surgical prophylaxis.
It's like a drastic change. Yeah, it's like a change of concepts because I think for Rada and I, back in the day, we used to refer to antibiotic prophylaxis to everything that we give before a surgical procedure that warranted, to have an antibiotic prophylaxis. Now they have introduced the concept of surgical prophylaxis, antibiotic prophylaxis, and endocarditis prophylaxis.
Yeah,
so those are 3 terms that we need to understand very well so we don't get confused, or you guys don't get confused when you are attending Euroskis.
So to summarize, there is no need, even for a patient with a profound immunocompromised status, to give any antibiotics prophylaxis.
Correct. Yeah.
So, as you can see, page 190, in patient with a profound immunocompromised condition or not, you don't give any more surgical prophylaxis unless you're going to do oromaxillofacial procedures, which is not, will never be the case.
Yes.
As a dentist, this is not our scope. So whether you have a pre-existing joint prosthesis or pre-existing breast implant, same, you don't give any antibiotic prophylaxis. They give you box 23, a principle to how to prescribe appropriately the surgical antibiotic prophylaxis. It's about the choice of antibiotics, we know, single preoperative dose, we know, how long before, so never more than 60 minutes before the incision. Other than that, basically you don't need to know anything, but just you don't give any more for anything.
Yeah, and they are here again, reiterating that patients with pre-existing joint prosthesis, they don't need any antibiotic prophylaxis, and they have included here a consideration for patients with pre-existing breast implants. Those patients are also not a candidate for any antibiotic prophylaxis. So basically, as Rada said, if you refer to table 18, pretty much nothing that we do is going to warrant any kind of surgical prophylaxis for any patient that we have. And then we have antibiotic choice for surgical prophylaxis.
So for the endocarditis prophylaxis, so you have the box 24, page 194. So you have to tick 2 boxes. 2 criteria are necessary to consider the endocarditis prophylaxis, antibiotic prophylaxis. So the patient should have any one of the conditions that are listed in box 24. Plus, the patient will have one of the dental procedure that is at higher risk of bacteriemia. So just quickly, implant, extraction, biopsy, removal of soft tissue or bone, like for instance grafting, subgingival scaling and root planning, replanting avulsed teeth. So in the old TG we had the high risk, moderate risk and mild risk. You could consider for moderate risk. Now it's no longer the case. It's only these patients, box 24, and only for the higher risk.
Yes, definitely. So if anything, I do think this is going to be less complicated than the last one.
Yeah.
Basically, the only thing that we will do is endocarditis prophylaxis, and then you refer to box 24 and you check where your patient fit in that table. If your patient doesn't fit in that table, they don't need anything at all. If the patient fit in there, then you go to box 25 and you revise all the procedures that Rada just read. And if those two matches, then you need endocarditis prophylaxis. And that's pretty much it. So if anything, I think it's actually more like less complicated, like easier,
I think
right?
They made our life easier.
Definitely.
And rest is same
because
antibiotics.
Yes, because the regimen is the same. Amoxicillin is the first line of choice, and then we have cephalexin or cefazolin, and obviously patients with severe or immediate allergy to penicillins, clindamycin. But that's pretty much the same as the last one. So I think endocarditis prophylaxis, or the entire chapter of antibiotic prophylaxis, is quite straightforward. We don't need to think too much. You guys don't need to complicate too much. Yes, it's super straightforward. Again, go back and read.
Yes.
And if you are not agreeing with us, if you are reading and you are saying like, oh, I think you guys missed something,
leave your comment.
Exactly. Let us know. Do a comment. Do a question.
We can talk about it.
Yes, and we can definitely talk about it, because as we have said many times before, we are not expecting to have, the reason and the last word for everything. Exactly. Because that's not the case here. We are just trying to do our homework, together with you guys. So if you think that something has been misinterpreted from this chapter or for any other episodes, just let us know, and give us your feedback and questions, and we will try to
This is what we call a healthy debate.
It's a healthy debate, which is quite hard to have nowadays. Exactly. Everyone has strong opinions.
We have to follow the mass.
I mean, it's just, it's healthy just to not agree every single time,
And that's why we are different, and that's why it's good.
True.
Okay. We are not robot. Anyway, so now let's move to local anesthesia in dentistry. Not many changes as well.
Yeah.
I would say that page 205, they added a table with the local anesthesia solution. So with the several ones, if it's short acting, intermediate acting, or long acting, with the indication, it is a bit more clear, more organized than having the paragraphs that we had in the old TG.
Yes. So table 19 is important from this chapter, guys. I think you have a very good summary of the anesthetic solutions that you will use if you are a dentist, and you are. So you can just refer to that one over there. And
so for the dose, they just say that you have to use the lowest dose necessary to prevent the patient from experiencing dental pain, but not exceeding the maximum dose, and same calculation. They've made a nice table just as the old TG.
Exactly.
With each...
I think box 26, I mean, what you have in table 20 is the same.
Yeah.
Box 26 is just a good example of how to calculate things.
It's the same as
the old one.
But it is more highlighted. They put it in a table that is purple, but it's the same.
You don't need to memorize all this. Remember, if you are facing an OSCE that warrants for you to have any calculations regarding the local anesthetic dosage, you will have your 3-minute reading time, you will have your TG next to you, your MIMS next to you, so you can just go and do it. A lot of people, they are a little bit scared when they go to the OSCE station, and I think they didn't even look, you know, they don't look around what they have, you know, at their disposal. And
you have TG, you have
exactly.
mints.
Because there are things in TG that definitely we need to know by heart. I mean, you need to know the dosage for your amoxicillin, 500 milligrams, you know, 8 hourly for 5 days. But if you are super nervous and you forget about it, you can just, during those pre-read-a-minute time, go in there and take a look. So same for this. You don't have to memorize all of these things. So for the ones that are new to part 2, you are going to have 3-minute reading time during your OSCE communication. Make sure, or even for the local anesthetic, skill OSCE, right? When you need to give anesthetic. If you need to consult anything and you are unsure because you are very stressed, go to MIMS, go to TG, you will have the time.
During the 3 minutes, enjoy that time to look around, and I mean, it's not enjoying, but you understood.
Have fun.
Have fun, laugh with the examiner.
Well, why not? I mean, I know that it's not a stressful environment for the new ones. I think we all go through any stress periods when we are preparing for this. But when you are there, you realize it's not that scary.
Yeah, after you went through it, you know that it's not that scary, and the examiners, they are really nice.
Yeah, they're very nice, very collaborative.
So
that's it. So basically for LA, that new table, table 19, page 205 and 206, just to have everything very well summarized about all the local anesthetics that we can use.
Now let's move on to discuss about anxiolysis. So minimal sedation for dental procedure. So they have added a few information regarding the definition of the anxiolysis that the practitioner, because we have variability in the effect of the drugs, so we must be prepared to manage any associated risk, which includes the added 4 points: oversedation or loss of consciousness, airway obstruction or respiratory depression, cardiovascular depression, drug interactions, adverse reactions, or anaphylaxis. Basically, that is the only difference here. They are talking about deeper sedation.
Yep.
So they include IV sedation and general anesthesia, and that is kind of out of our scope of practice. So you don't need really to.
Yeah, I think if we ever come across with a patient that cannot be treated on the chair, we will need to refer the patient because it's not possible. But I think as a rule of thumb here in Australia, you try to manage your patient anxiety, to build a rapport with the patient, try to make as comfy as you can the environment for the patient. If after you have exhausted all of those measurements, definitely the patient is not coping, then you need to refer it. I think that's quite important to highlight, because it's not like, oh, you are anxious, go and have GA, or go and have intravenous sedation. It's not the way it works. So if you
have things in between
to
help the patient to cope with his anxiety. So first is rapport building and all that. Then we can shift to oral sedation. If still doesn't work, we can go to more deeper sedation.
So yes, again, we are just saying that to you guys. So we don't take anything so literal here. Remember that we need to translate this into a real life situation in the context of ADC practical examination. The real situation will be your OSCE communication station. So if you have any of these, you just need to try to build a rapport the same way that you will do it if the patient was a real patient in your real life.
And again, anxiolysis management means also that you have to assess your patient. So we can't give like that, oh, I feel you're stressed, have a pill, you'll feel better, we're going to have a good laugh. No. So you need to analyze and determine the suitability of anxiolysis. So you have several points here again. here, very well made, page 213, a table
Yes.
with the patient groups with the increased risk outcomes, adverse outcomes, with the minimal sedation. Previously in OTG, it was more written under each medical condition in the
Yes.
paragraph, in the chapter related to the medical condition management. But here they just give you some good summarize of who cannot receive sedation and for which category it is contraindicated, which is saving you a lot of time. Yes, so it's very good, very well made.
Yes, so basically here you want to watch for every single bullet point in here. Yeah. Obviously children younger than 2 years, I don't think we will ever treat, with minimal sedation children so young, but if you ever have that thought, just reconsider, because it is a group that is at risk. Elderly or frail patients, patients with severely limiting heart, cerebrovascular, lung, liver, kidney disease. Because remember that we are, even if this is nitrous oxide or even if it is any benzodiazepine, we are administering a medication. So we need to take in mind the route that the medication is going to take through the body. That's why it's quite important lungs, if we are talking about nitrous oxide, and liver and kidney, very important for benzodiazepines, So I think, again, this is just to try to exercise, your analysis behind this. It's not just because it's written here. It's written here because of a reason, so we need to do that analysis.
Because you're going to see a real patient.
True.
And you're going to treat them for real. It's not just for the sake of passing
ADC.
ADC. It's also to apply in your life practice.
Yes. Obese patients, significant obstructive sleep apnea, patients with a known suspected impediment to endotracheal intubation, patients with a history of acute gastrointestinal bleeding. I think all of these patients, if you have taken a very good medical history, the first time that you see the patient, you will pretty much spot this quite easily. Yeah. So if you have spotted, you don't even going to consider any of these alternatives for those kind of patients.
Correct.
Okay, so for minimal sedation is also new here.
So here they are
yes.
talking about the advantages and disadvantages of the oral and the nitrous oxide, so the inhaled sedation. So the advantages and the disadvantages, something which is new and surprised us, or particularly me. So they have written and indicated that oral sedation is not suitable for children and adolescents unless you're a specialist, you're in pediatric dentistry.
Yeah.
So which was not
included previously
in the old TG. What else?
I think, well, basically, just for you guys to be very clear, for minimal sedation, the options are nitrous oxide or benzodiazepines orally. If we are talking about benzodiazepines, adolescent and children, it's a no-no, unless a pediatric dentist administers that. And for nitrous oxide, basically, you will need to be trained to use it. You need to have some kind of certification.
Training, yeah,
that's
correct.
Okay.
So what is new in the benzodiazepine chapter paragraph? So we have page 2017. They added more benzodiazepine medication. So we used to know about diazepam and temazepam, but now you have lorazepam and oxazepam. So they are giving you a good table with the time to peak plasma concentration and the elimination half-life, and they are giving you the indication. So for adults that are not at an increased risk of adverse outcome, you are going to use lorazepam or oxazepam or temazepam.
Yeah.
But if you need for a longer duration, which means that the half-life elimination is longer, then you'll go for diazepam. Before, there were no differentiation between the long or short, procedure. You would go for diazepam or temazepam straight away. Here they have separated the two.
Yes, and they have written here as well that if you have spotted that your patient is in increased risk of adverse outcome, basically what you need to do is to use a lower dose. You know, especially for diazepam because the half-life is so long.
Yeah.
So you will
1 to 5 days.
Yeah, and obviously if you are not sure, you can do a referral for a GP. Mm-hmm. I do remember that recently I had a patient and she is very, very anxious and we work very well, but at the end of several appointments, she decided to go to the GP. The GP prescribed Valium for her, and in that way, I'm completely, you know, free of responsibility. The GP has done the prescription appropriately for her and everything, and the GP assessed her about the entire Valium, and in this case, well, it was the diazepam, the commercial name, but it worked very well. It was very good for her. So if you guys feel that you are unsure about going ahead and prescribe this by yourself, you can always, you know, have some support from the GP, and that's what I did. I told her, like, if you have done, because she told me, like, I have done this before, I have taken this before, and I was like, okay, who treated you and gave you that? And she told me my GP, and I was like, okay, let's consult with the GP, and the GP was agreeing with us, and that's why she took the diazepam. So I think there's different ways to try to look for support in these cases, because we don't want to create any kind of, you know, adverse outcomes for the patients.
Rest is quite similar
Pretty much the same.
All the adverse effects similar to OLTG. So for the nitrous oxide, again, it's the preferred agent or way to manage the anxious or incooperative children.
Yes.
But you must have the resuscitation equipment. Basically, there is nothing really new. It's like the OTG.
And again, same as you will do with benzodiazepines, you just go to box 27 that has all the list of patients at risk, and that will apply also for nitrous oxide. But everything else is pretty much the same.
Yeah.
Yeah, so I think that's pretty much everything.
Yeah.
So we have covered today the changes in antibiotic prophylaxis, the changes on local anesthetics, and anxiolysis. So I think, as you can see, there are not too many changes, small things that you need to keep in mind. Again, go and read. If you have any questions, just submit the question to us, and we will be happy to look into them and answer them. And I think that's pretty much it. Anything else, Rada?
No, I'm fine.
All good, guys. So
see you in the next show.
Stay tuned.
Take care.
Bye.